All right. We're going to spend a few minutes just giving you a little background on the outbreak going on right now. But then the whole goal of this was really to try to get nuts and bolts on how you guys get your hands on these 4 new therapies to help your patients. And so you want to say the usual lines here?
Yeah, thanks for these reminders here. So this is a reminder that we do record these sessions. If you have any concerns about being on that recording, let me know. We can edit you out. Reminder, if you discuss patient with us here today, not to disclose protected health information such as patient name, date of birth, occupation, those sorts of things. And a disclosure policy so we can provide CME and CEU credit for today's session, just letting you know that none of our presenters have any relevant conflicts of interest to today's content.
All right, we're going to start off by what we're not talking about. The CDC new isolation policy is very simple and straightforward as solving a Rubik's Cube. And obviously, nobody understands it. And they hired that lady, doctor, whatever her name was, but it's actually gotten worse. So what can you do? Anyways, so we're going to talk about just a little bit background what's going on with Omicron, which is, turns out Omicron is the most rapidly spreading infection in the world ever. It beats out measles, pandemic, flu. There's nothing else like it. The spread is unbelievable how fast it was. And we saw just the beginning of December, in 4 months, it went up to 98% of all isolates and new cases. It's amazing, as we all know. And the estimates are that as many as 6 million Americans are getting infected every day, which is a fantastic number of people, obviously. And that's the bad news. The good news, it looks like we're going to be very similar to South Africa, where we've had this unbelievable peak. And at least on the East Coast, where it hit first, they're about 2 weeks ahead of us. They're starting to see a rapid decline in number of cases. And so this hopefully will continue as it moves across the country. This is a map. It's updated every minute. I got it last night at midnight or so. And what it basically shows is the darker the color, the increasing number of cases. But if you go on the West Coast where these light colors, I think that's New York. I used to live there. Down 21%, 44% New York, that Pennsylvania, Washington, D.C. So we're seeing that this wave, which started off on the East Coast and it's moving westward, we're seeing at the same time, 2 weeks ahead of us, significant drops week to week, which is very encouraging. And this is something I found in the New York Times. This is crazy. This is a company called Kinza. It's a San Francisco company that has 2.5 million internet-connected thermometers across the country. I don't know how they did this. And what does it checks the data to see how much fever is going on with these 2.5 million cases. And so we saw December, the increase up to about here. And now in the last week or so, it's starting to go down. But what you see, the fever is going down, particularly in the Northeast, which again, 2 weeks ahead of us. And we're seeing some plateauing out in the South, and the West is also starting to go downhill. So this wave looks like of resolving infection numbers are going westward, which is very encouraging. And this was out of Kaiser. They wanted to look at actually how severe these infections are. And what they did was they took almost 70,000 of their Kaiser patients. They matched them for clinical characteristics, whether or not they were vaccinated, et cetera. And they compared it to first we had the original, then we had the Delta, which was killing everybody a few months ago, now the Omicron. And when they used matched patients, in terms of symptomatic hospitalization, they found a 50% reduction in their patients. ICU admissions were down 75%, and deaths, Omicron compared to the Delta, but with matched patients, vaccinated, unvaccinated, 91%. So again, we have some evidence that it seems to be a less nasty virus. And this is the world's documentation. These are the number of cases across the world, and these are the number of deaths. And so what we're seeing that even though the cases are skyrocketing and they went up with the Delta spike and the original spike, deaths are continuing to drop across the world. So that's encouraging. And when they try to look at what's responsible. Part of this improvement is the fact that billions of vaccine doses have been given. Part of it is people have had prior infections. And they estimate that the Omicron is about 25% less virulent. So it's a combination of vaccinated people, prior immunity, and a less virulent virus. And they were saying, could you imagine, we're so lucky that this was a less virulent virus. If this virus had been like the Delta virus or worse, we would, the world would probably be over at this point. So we really dodged a bullet with this virus. And this is also, people say, oh, why should I get vaccinated? So this is, if you remember when this is all the mutations in the Omicron virus. There's about 50 different significant mutations. But despite this, let's compare it. The ancestral strain was the strain we had, the beginning of 2020 when it first came out. And remember, the mRNA viruses, they were fantastic. They had a 95% reduction in the risk of hospitalization. But with the Omicron, if somebody had only gotten 2 shots, didn't get a boost, we found overall about a 50% chance of reduction, which is not great. But if you got the booster within 2 months, overall 90% reduction in risk of hospitalization. If you look at people over 65, 95%. So two mRNA vaccines with a booster, 95% risk of reduction in people over the age of 65, the ones who are most risk for bad outcomes. So 2 shots and a booster works beautifully in terms of protecting people from hospitalization. And again, this is another study. And what they actually looked at, what was the risk of hospitalization? If somebody had just 1 dose, the risk of Omicron versus the prior, about a 58% reduction in hospitalization. 2 doses, about a 44%. But if you got a 3rd booster after 2 to 4 weeks, 92%, 5 to 9 weeks, 88%. After 10 weeks, you had a booster, still about an 83% reduction in hospitalization. And what's interesting now is, your risk of a 65-year-old person dying of the flu is about 4 times greater than that same person getting Omicron who has been boosted. So actually, the flu at this point for an older person who's unboosted is a greater risk to their health than Omicron. And this was just to show you in Chile, which was one of the countries that had an outbreak before we did. When they looked at unvaccinated or not fully vaccinated, they looked at death rates. And the death rate was about 3.26 per 100,000 people. If they're fully vaccinated, 0.063, if they're boosted, down to almost no deaths at all. So everything points to a better outcome, particularly in people who are vaccinated. And this is probably the most interesting, just children. Children, we can't say what affects the boost under age 5. These kids have not been vaccinated. So they were able to, this study, look at children within the first 3 days of their diagnosis in the Omicron group versus the Delta group. And so in emergency visits, they found there's about a 0.71 likely less. The relative risk of going to the emergency room was down about 30%. If the patient getting hospitalized, it was down about 67%. ICU admission was also down about 68%. And mechanical ventilation was down to over 71%. So if looking at kids, they're not affected by vaccination statistics, but again, in children, they seem to be handling it much better than the Delta virus. And just, I say people in this country complain about masks, but this is a video from China where these were little kids dressing up like going on a SpaceX trip, and they were going to kindergarten, and they were all dressed up in these amazing suits. So I think we shouldn't be complaining about masks when we could have a kid looking like that. Right? There's one interesting thing that is still not clear yet, is this question about neurological involvement from Omicron, because we know that even in the Delta virus, where you have asymptomatic or mild cases, there's about twice the risk of some neurological findings called brain fog. They don't know, even though we're not being affected by our lungs, it has what's called immune mimicry, whatever. The immune system isn't recognizing Omicron, and it may be having more time to get into the brain and may cause issues with neurological side effects. We really don't know. So we know that at least medically, these patients are not ending up in the hospital because of the respiratory status, but it's not clear whether or not Omicron may still have neurological findings. And so there was this article in the Wall Street Journal a few weeks ago, a week or two ago, encouraging everybody to get Omicron, get it over with, when we really don't know what the long-term effects of Omicron may be on, particularly on the neurologic or some coagulopathy type symptoms. So that's just something to say, oh, let's just get it over with. All right, so what I want to focus now on this meeting is there's 4 new outpatient treatment options for at-risk patients. One is the outpatient infusion of Remdesivir, one is a new monoclonal antibody, and 2 new oral options. So I'm going to just highlight Remdesivir and the monoclonal antibody, and then I will pass off the new oral options to our pharmacist. So Remdesivir, we all know, is used with patients who require oxygen to get admitted to the hospital within 10 days of onset. But the question was asked, how about if we can identify patients with at least one risk factor? And in this study, it was age greater than 60, or they had obesity, or some kind of coexisting medical condition. They were then randomized to an outpatient study. They weren't hospitalized. They didn't need hospitalization yet, but they had a risk factor. And what they were given was a 200 milligram loading dose of Remdesivir, just like you did in the hospital, followed by the next 2 days, 100 milligrams and 100 milligrams. And they were randomized about 280 people to the infusion, 280 people to the placebo group. And what they found out was very remarkable. I believe it was in the Remdesivir group, only 2 patients ended up being hospitalized. In the placebo group, 15 patients. So this is what they found out was, what was the risk of being hospitalized? Placebo up here, Remdesivir down here. And so they found out that this simple outpatient infusion of Remdesivir with 3 doses reduced the risk of hospitalization by 87%, which is really very remarkable. And I said these were only patients over age 60. I think they had to be given it within 5 days of symptom onset, or 7 days. So this was 7 days, 3 days of Remdesivir over age 60 or one medical problem, and it reduced hospitalization by 87%. So that's one option. The second is the monoclonal
Sorry,
antibody.
Dr. Krasner, just real briefly, we got a question here from Dr. Bayan asking, did those 3 doses include the loading dose?
That's what I said. Yeah, the first dose was 200 milligrams. So it was 400 milligrams given to them over 3 days. But the loading dose is the same as in the hospital: 200 milligrams, 100 milligrams, 100 milligrams. All right, so 87% reduction, Remdesivir. The second is the monoclonal antibody infusion. If you remember, the monoclonal antibodies basically are antibodies selected as they bind to the surface spike protein, neutralize it so it can't bind to the ACE receptors on the human cell. And so what happened was that we were using Regeneron, but what happened is that Omicron had so many mutations that Regeneron and the Lilly products no longer were able to neutralize the antibodies. So we stopped using Regeneron since 98% of cases were the Omicron. But there was a drug called, I always have trouble, how would say it, Sotrovimab, which was also in a study where they were looking again at efficacy versus the Delta virus, the old one. It showed also a remarkable benefit, but it also worked on a different part of the protein, the spike protein, that was not addressed by the other products, and it seemed to pick up its where it bound to seemed to have more consistency. It was not affected by the mutations that much. So the question was, how efficacious would this drug be against the Omicron, which Regeneron no longer works? And they have not actually done a study with this. What they've done is their own study. This is the study against the Delta virus, where they, for example, when they gave the 1 hour infusion, only 3 people got hospitalized versus 21 with the placebo. So we knew it worked very well, at least against Delta, but we're dealing with Omicron. But they were able to do some in vitro studies, seeing how well it neutralized. And these in vitro neutralization studies seem to correlate with clinical outcome. And so what they found out was, while Regeneron had no activity, Sotrovimab had probably a 1/3 to 2/3 reduction in activity, but they felt it'd be enough to give some clinical benefit. Okay, so this is the new monoclonal antibody, which is being used. Again, it's never been studied in Omicron, but in the lab would suggest that it would have some retained efficacy against the Omicron virus. And so a single infusion of the monoclonal antibody, Sotrovimab, lowered the risk of disease progression without an increase in adverse effects, again, against the Delta virus, but in the lab, it appears to be somewhat efficacious against the Omicron virus. All right, so I'm going to turn this over to our pharmacist for our next two drugs.
Adrian, I believe, is going to present.
Okay.
Yeah, Adrian, can you unmute yourself? And sorry we didn't get to you during introductions. If you could introduce yourself as well, please.
Hi, can you hear me?
Yep.
Okay, let me start my video and I'll share my screen. So it's nice to meet all of you. My name is Adrian. I'm one of the PGY2 ID pharmacy residents here at Renown. So I'm going to go over some of the oral options, and let me just see if I could share my screen. I don't know where that button is actually.
So it should be on the Zoom, like the toolbar where you mute yourself or you start your video. Right in the middle, there's the green share screen.
Oh, perfect.
And then
Thank
you click that, find your PowerPoint, and then there's a blue share button, and then it should show everything.
Yeah.
Perfect. And then you can just put it in presentation mode.
Yeah. Just this. Okay. All right, sorry for those technical difficulties. So we're going to go over some of the oral COVID-19 treatments. So those two treatments are Paxlovid, so that's Nirmatrelvir and Ritonavir, as well as Molnupiravir. So these are oral antiviral agents. Currently, they are not FDA approved, but they are approved through an emergency use authorization by the FDA. They are for the treatment of mild to moderate COVID-19 for individuals who are at high risk to progression of severe disease within 5 days of symptom onset. So I really want to emphasize that this is for outpatient use primarily. So patients not requiring oxygen or hospitalization or increased oxygen requirements from baseline. So you want to make sure that before prescribing this medication, that you read the EUA fact sheet for providers for all that information about these two medications. So firstly, we're going to talk about Paxlovid, Nirmatrelvir, and Ritonavir. So the mechanism of action, Nirmatrelvir is a SARS-CoV-2 main protease inhibitor, thus inhibiting viral replication. The Ritonavir, while it's not active against the SARS-CoV-2 virus, it works to boost the levels of the active drug, the Nirmatrelvir. So you can see that kind of cool graphic on the right side where Ritonavir is boosting up the Nirmatrelvir levels. So the EPIC-HR study was a study that looked at Paxlovid, and it found that it reduced COVID-19 related hospitalizations or death from any cause through day 28 from 6.3% to 0.8%. That was a reduction relative to placebo. And you can see that was statistically significant given that the confidence interval did not cross 0. So this is what the packaging looks like. So it's one blister card relates to 1 day of treatment. So on the left-hand side, you can see you have your daytime tablets, and on the right-hand side, your nighttime. So this medication is indicated for 12 years of age and older, weighing at least 40 kilograms. It is renally dose adjusted, but if the GFR is greater than or equal to 60, you can give the full dose. And so that full dose is 2 tablets of the Nirmatrelvir, along with 1 tablet of Ritonavir, with the doses shown there. And this is taken for 5 days, so morning and evening. Now, if you need to renally dose adjust this medication, that's done when the patient's GFR is between 30 and 60. So what is you'll actually remove one nirmatrelvir tablet from each side, so from the morning and the evening side, and then you'll put a sticker provided by the manufacturer over the areas that you punch those tablets out. And so currently, we have just been recommending to discard those tablets. And the pharmacist does that before they provide the medication to the patient. And when they do provide the medication and put the labels on, the labels are sure to say that this is renally dose adjusted with only 150 milligrams of nirmatrelvir twice daily instead of your 300 milligrams twice daily. The ritonavir stays the same. So contraindications for this medication, patients with a GFR of less than 30 should not be using this, or severe hepatic impairment, Child-Pugh class C. It was not studied in, so it is not recommended for these patients. Or if they have a history of hypersensitivity to any component of Paxlovid. But the biggest contraindication, and really what kind of limits Paxlovid's use, is the myriad of drug interactions that we have, specifically with medications that are dependent on CYP3A4 for clearance. So you can go to that handy drug interaction checker website that looks at all the new COVID therapies and if there are any drug interactions that you need to worry about. So with this medication, if you look in the EUA for healthcare providers, they actually have a pretty good list of medications that you should be looking out for, whether or not the levels are increased or decreased when co-administered with Paxlovid. So some of the primary ones are going to be antiarrhythmic medications such as amiodarone, digoxin, dronedarone. You could see increased levels of those. So they are considered generally contraindicated with Paxlovid. Different antineoplastic agents, HIV medications, anticonvulsants, statins. And one thing to note is ethinylestradiol levels can be decreased, so patients should be using backup contraception when taking this medication. And if you're interested in more of these drug interactions, you could actually look at that EUA for more information. So some side effects and count. Yes?
I want to point out back on that other slide as well, that that drug interaction website that's listed there, that COVID-19 drug interactions, has been really helpful because it actually is, you're able to type in the drug and the drug list of what the patient is on, and it will tell you the severity of the drug interaction and what actions might need to be taken in order to either proceed or if there's no way around it.
Thanks, Heather. Yeah, that's a really great point. So really fantastic tool that's there. And now for some side effects and counseling points, as well as pregnancy concerns. So you want to make sure that these tablets aren't crushed, broken, or chewed. You could take them with or without food. And once again, if using a hormonal contraceptive, it's recommended to use a backup method with a barrier method. So the most common side effects they noted in the study were taste distortion, diarrhea, hypertension, and myalgias, but the overall incidence of these side effects was fairly low. And of course, those drug interactions that we discussed. And with pregnancy, it's really important to weigh the risks and benefits. So they did do studies in rabbits where they noticed low birth weight. They did not see that in mice. And ritonavir has been used safely in pregnancy. So it's really a risk versus benefit, but no direct causation has been linked to this medication causing birth defects, aside from that low birth weight in rabbits. So I did want to point out that this slide is a little bit outdated. We actually have some recent updates to this. So it is true that allocation is currently at the discretion of the Nevada State Board of Pharmacy. And while initially limited quantities were being allocated to hospitals in large population areas, more hospitals in rural areas have been getting access to this medication. So if you're interested in having Paxlovid at your facility, it's recommended that you reach out to the Nevada State Board of Pharmacy so they can coordinate that for you. And so we're seeing increases in production. And as we see more of that, increase, availability is expected to continue to increase. Something that has been prohibiting increased production is because the packages, like I showed you, come as those blister packs, and some of the medication is wasted in renal dose adjustment. It is making it a bit more difficult to ramp up production as quickly as they would like. But we are seeing an overall increase, though more slowly than we would probably like. So next we have Molnupiravir. So while this is approved, while this does have an emergency use authorization, it is not yet available for use. It hasn't yet been distributed. So it is currently indicated for patients 18 years of age and older for whom alternative COVID-19 treatment options are not accessible or clinically inappropriate. And if you remember, this is for mild to moderate COVID-19, so non-hospitalized, not requiring increased oxygen. So its mechanism of action, it's a prodrug of a nucleoside analog, and it actually has antiviral activity against the SARS-CoV-2 virus. So this nucleoside analog is incorporated into the viral RNA, which causes a whole slew of issues in the replication process. So the MOVE Out study was what looked at the efficacy of this medication. So they found reduced all-cause hospitalization or death from day 20 through day 29 from 9.7% to 6.8%. And that reduction was relative to placebo. And you can see that was clinically, or that was statistically significant as that confidence interval didn't cross 0. So the dosing, this is 800 milligrams or 4 200 milligram capsules twice a day for 5 days, and no dose adjustments are needed. So contraindications, there actually are no contraindications to this medication or drug interactions. So this could be potentially used as an alternative for patients who cannot use Paxlovid due to drug interactions. It is not recommended for use in pregnancy due to embryo fetal toxicity. So that's very, very important to remember. And it's not authorized for patients less than 18 years of age because it might cause bone and cartilage defects. And so if it is prescribed during pregnancy, there's a disclaimer there that Merck has that they need to document that the individual who's given this medication, that there could be birth defects associated with it. And then they need to register for this pregnancy surveillance program. So for Molnupiravir, they also have this checklist tool for prescribers. And so there's the link for it right there if you're interested. It basically lets you know that you need to provide this EUA fact sheet to the patient and discuss side effects of the medication. And then if the patient is of childbearing potential, they should be using contraception while using this medication. And it provides information on pregnancy. So side effects of this medication, you do not want to crush, break, or chew these tablets, and you could take it with or without food. Main side effects are diarrhea, nausea, and dizziness, as well as that risk of fetal toxicity and bone and cartilage toxicity in children. So you want to make sure that females and males of reproductive potential who are sexually active use a reliable method of contraception. And they should use this consistently for the duration of treatment and for 4 days after the last dose. And it's recommended to also withhold from breastfeeding through treatment and 4 days following treatment. And so that was everything I had. And I think Heather can help answer any questions you might have.
Appreciate it. Thanks, Adrienne. Yeah, there was Kim shared a comment. Kim, could you clarify your comment there, please?
Yeah, of course. So there is actually a COVID-19 therapies finder, and it includes both of the orals and EvuShield. And this can be used across the country. It includes the entire United States and allocations that have been sent to pharmacies and hospitals. So as part of the filter features, you can filter based on state, zip code, and whatever, and figure out which local area pharmacies have what in stock, even the local hospitals as well, because it's all reported up to the US government. They include also typically the courses supplied at these pharmacies as well. Granted, I can't say that they're 100% accurate, but they'll give you an idea of how much is in stock at that particular pharmacy. So especially for us at the VA, we have patients that cross the state lines quite a bit. They live in either Northern California or sometimes in Central California. It's helpful because then if they can't come to the VA, we might be able to send them to, a pharmacy nearby to them.
The tough thing is though, I mean, getting a test, first getting yourself tested, getting a hold of a physician, and all within 5 days seems almost impossible these days. It seems very frustrating. I don't know how a patient and doctors are going to be able to do this.
We offer all of it. So, I mean, for us, we actually had to do, because we're trying to contain everything within the VA. We offer Remdesivir infusions outpatient. We have a small allocation of Sotrovimab. We have to actually use a point system and in the NIH tier system because the allocation is so small. And once our VA stockpile is depleted, we won't receive any more. But those are the other two ones that we have within the VA, and we're trying hard not to use the community because we know these are so limited and trying to keep them within our healthcare system.
I would think the best chance is that you get yourself tested and go to the local hospital and see if they have Remdesivir or the monoclonal antibody, if you can't get these other medicines. I mean, they all seem like they're pretty much interchangeable, the Remdesivir, the monoclonal antibody, and the Paxlovid, or whatever it is, as all excellent choices. But again, it's how do you get to there in the 5 days?
We're finding that the limitation with the Sotrovimab, though, and even the Remdesivir is the infusion time. So you have to have an infusion chair or an ER bed for, an hour to 2 hours, especially with the monitoring. And so we're really pushing the oral options first. And then if they don't meet criteria, then to go to the monoclonal antibody or the Remdesivir.
So the ER
right now,
doctors
we're not
are
actually doing Remdesivir. What?
Okay. They'd go, have you prescribed in the oral agents yet at Renown?
Yeah, we are. We've gone through, I think, roughly 65 courses now of the Paxlovid.
Wow.
And so, or not 65, sorry, 105. We have about 60 remaining at the moment. But yeah, we've done quite a bit of it. We're seeing a lot of use from the community come in, and we're filling it at the emergency department. For a long while, we were the only place in town that had it. And so everybody was having to come there to get it. Now it's very nice that some of these other places have picked it up and have the availability to dispense it.
Is the patient charged for the medicine? If the EUA, is there a charge does it cost the patient? Or how does it
No,
work?
so right now there's no charge to the patient. So the patient shows up with a prescription and we dispense it. We'll go over the EUA and then dispense it to the patient. One of the biggest challenges I think that we've had is with renal function, and just knowing if that patient has reduced renal function, or even just pushing out those tablets and trying to make it look nice with the sticker is really, honestly, feels ridiculous to try to do, but it doesn't look nice. It comes as this nice packet that's supposed to work really well, but it doesn't. And so trying to explain that to patients is a little bit challenging. But overall, the renal function's been the biggest issue, and then having to complete a medication reconciliation at the emergency department when we're dispensing is the other challenge of that. So it helps if that's already been completely vetted.
I mean, it seems that would be one of our comments would be the best choice for a rural hospital that doesn't have, short of nurses and doesn't have the Remdesivir to be able to get that medication available.
Yeah.
So
Go ahead, Charlie.
how should those hospitals in the rurals, what should they do now to try to get some of that stocked in their ER?
Yeah, so we reached out to the Board of Pharmacy even just this morning, just to make sure that we were on the same page, but they are increasing the access to the critical access hospitals in the rural areas right now as they've ramped up production. And so they are starting to distribute that more widely. So if you haven't heard about a distribution to your area, I would really reach out to the Board of Pharmacy because that is the next areas where they're really trying to ramp up the oral agents too.
Yeah, I know we've got quite a few of our rural locations on here today. So yeah, any other questions from you all, feel free to unmute yourselves or keep writing in through the chat box, please.
Ask Ken Fernandez said something. Can tell us.
Yeah, a comment from Dr. Fernandez here was currently we have no Paxlovid in Lovelock. It would give us another tool against the Omicron variant.
In the meantime, you're welcome to send them to Renown to pick it up, but that takes quite a bit of a drive, I understand. But we have seen some of those patients from at least Fallon where we have had to dispense it for them. Hopefully not for long, and you'll get your supply.
And are the patients that you've been giving, Heather, are they been vaccinated or unvaccinated people? Are they risk factor people, or what? Tell us about them.
Yeah, so we've had quite the array, actually. Interestingly, in this EUA, although it says mild to moderate COVID-19, it does not actually exclude out those with oxygen requirements. So long as you are going home and you are still considered mild to moderate COVID, you are technically a candidate for it. We have seen those with several risk factors. We've also seen patients where they've had very minimal risk factors. And so it's the whole gamut. We've seen vaccinated and unvaccinated. The Paxlovid group actually has some other trials coming out where they are looking at vaccinated groups versus unvaccinated to see if the benefit is there. That data is not available yet. So it'll be interesting to see how that teases out. But right now, we are not excluding those who were vaccinated.
Question here from Dr. Van Gilder. Will this only be available via ER visits?
No, so long as you've been seen by a provider or there's a prescription for it, you can just show up and we'll dispense it to you and you don't have to check in. I think that's true for some of the other places around town too. I think Community Health Alliance and some of those others. However, if you don't have an active prescription, so you haven't seen a provider and they haven't written that, then yes, you would have to check in and then have one write it.
Kind of a continuation here from Dr. Bayun. Will paper prescriptions be acceptable statewide since patients will have to hunt different pharmacies?
Yeah, right now, I don't think that there's a big capability to electronically prescribe it just for that exact reason. We don't know where it's at. And for instance, in the ER, I don't have a way to accept an electronic prescription. So it can be printed or it can be handwritten, but it does probably need to be actual paper prescription for the moment until we have a regular supply that has hit most pharmacies around the state, which I don't anticipate that happening anytime really soon. So a challenge too, when you're writing that paper prescription is just remembering that that if we have a renal dose adjustment to bring down the tablet quantity to 20 and to make sure that you're only giving 2 tablets twice a day of the Paxlovid instead of the 3, because any clarifications we have to make are, take time and challenging as well.
Just a second, Norm. Dr. Levy shared the email pharmacy@pharmacy.nv.gov. Heather, is that the best place to reach out to, or is there another contact you'd recommend?
Yeah, you can get a hold of him. The other person you could reach out to directly at the Board of Pharmacy would be the secretary, who is Dave Wiest. And so through that Board of Pharmacy website, you can look for his email directly and email him. He's been the one that we've been in contact that's been managing our allocations.
Yeah, I've actually been in touch with Dave before, so I'll share his info through the chat box for everyone. Norm, yeah, please go ahead.
Yeah, hi, Dr. Krasner. Thank you very much for bringing it back to vaccines. And I want to wish everybody, you and Troy and everybody, a happy new year. I'm really interested. One, I want to also say from a pharmacy standpoint, I'm not a pharmacist, I'm an RN. You guys did a really terrific job in bringing and making a complicated subject very simple. Thank you. But Dr. Krauser, I want to ask you about the vaccines. And one thing I'm seeing is limited in the data is one, we do not have it divided between the 3 different vaccines, which is more effective. And I really hope somebody would start doing studies like that. Or if anybody knows of any studies, could you please contact Troy or whoever and get the information to me? I'd be interested. And also, I think we need to study the effect of the boosters versus the non-boosters and how they prevent hospitalization, along with the medications that we've discussed about here. Thank you.
Sure.
All right, any other questions for our panel before we close today's session?
Wait, Heather, are you guys giving infusions of monoclonal at Renown, or you even have a supply of it?
Yeah, we got the supply yesterday, actually, of Sotrovimab. So we are giving them through our outpatient infusion center on Monday, Wednesday, Friday. I think there's only a minimal capability of 4 patients a day on Monday, Wednesday, Friday, just because of a shortage in staffing and nursing. So the majority of our infusions are actually through our ER, and we have started those infusions. Like I said earlier, right now we're limiting that to patients that don't qualify for Paxlovid, who are maybe in that 5 to 10 day window and are high risk. And then our OB group has preferred to use the monoclonal antibodies instead of the oral agents, just because of the unknown risks in pregnancy with the oral agents and some of the animal data that's out there on those. So that's our primary use right now.
That makes sense. I mean, we use Norvir for AIDS patients, pregnant AIDS patients, like the safest drug in the world. And, that was the preferred agent for the treatment of pregnant HIV women. That the drug that goes with it, though, obviously hasn't been studied.
This is Dr. Van Gilder. Can I just ask a question?
Yeah, please go ahead.
Hi there. Thank you again for the great presentation. I received a letter from CVS Health that listed pharmacies in Nevada that are going to be carrying the oral antivirals, instructing us to only send to these pharmacies prescriptions for this. Does anybody else know anything about this or receive anything like it?
Is that just for CVS, or is that for all pharmacies? They're just giving the CVS pharmacies that will have it?
Yeah, it was just CVS that listed particular CVS locations available that will have this in Nevada. There's 2 in Carson, several in Las Vegas, and like 5 in Reno. No, 4 in Reno listed.
Well,
I haven't called them to verify yet.
I haven't heard that. I appreciate Kim's post there of that website. I think that's probably going to be your best bet in terms of finding up-to-date options. But it sounds like it's starting to go more widely, but I haven't heard that directly from CVS.
Thank you.
And just filtering on that website, I mean, it looks like Walmart pharmacies have it, and I've seen it at a couple other, like maybe mom and pop ones too. So I'm not sure who was determined to get it or not, but you can filter that website based on, I think, zip code, county, city, state.
Tell us that one more time, Kim. What is it called?
It's the healthdata.gov one, and it's like the COVID-19 therapeutics finder, but it's only for the orals and Evusheld. It doesn't include everything on there, like the other therapeutics like Remdesivir, Sotrovimab, because I think those would depend on other things. And Troy just put it back in there, but it's for across the country, across the US.
Well, that's nice.
It includes
That's very
VAs
helpful.
too. So if your patient's a veteran, you can always ask them to try to get it through their VA rather than using your local area pharmacies as well.
Do we have it here?
Yeah, we have both. We have both Molnupiravir and we have Paxlovid. So, and we have also Sotrovimab and Remdesivir.
Kim, can I ask you a quick question? Are you
Sure.
using the Molnupiravir frequently?
We haven't used it frequently. We're probably going to prefer to use Paxlovid just based on the NIH's criteria. They recommended Paxlovid as kind of like your first line. And then if the patient had contraindications, then you could probably consider Molnupiravir at that point. A lot of our vets are on a ton of drugs that would have drug-drug interactions with it. So I won't be surprised if we have to switch gears. Most of my population is always complicated, so.
I would say in terms of the drug interactions, and I don't know if this is your reality too, is that although that list seems daunting, some of them, like the statins, we just technically tell them to hold it for the course of the drug. And so there's been ways around of a lot of them. It gets a little more complicated when it is truly going to cause a detriment. But for the most part, we've been able to get around a lot of those.
And we had the same experience when it came to the Hep C drugs too, because they, especially some of the fewer ones, like I think Zepitir was one of the first ones that came out that had a ritonavir backbone. And since we work with Dr. Krasner, and we used to use boosted ritonavir quite a bit in clinic before the newer HIV drugs were available. You know, Carol and I mean, we've had experience with the ritonavir therapies, fortunately, through those methods. So it's not as bad. It's just really like if it's this hard contraindication that, you know, you have to kind of switch to something else. And it's not going to be just the two of us processing these, because we can get these at all hours since our ER is open 24/7 too.
Really great discussion, really great information shared here today. Thank you all. Any last questions before we wrap up?
The end is in sight. Hopefully.
Thanks, Dr. Krasner.